everybody. I'm delighted to welcome you to our 8th Masterclass in our Neurodiversity series. Today is the 23rd of September 2021, and I'm delighted to bring to you on behalf of UCD Neurodiversity Project, the neurodiversity group working here and internationally with colleagues in Australia and from the UK. And today we are getting the administrative support from the CHAS and UCD from our tutor. So thank you very much for that. And as usual, Kim Kilbride from ADHD Ireland is also joining as a panelist to help field your questions and to contribute to the discussion at the end. So my name is Fiona McNicholas. I'm a child and adolescent psychiatrist working clinically in a paediatric hospital and in a community child and adolescent psychiatry service, and also working in University College Dublin. And I really am delighted to welcome our guest speaker today, Dr. Mary Doherty. Dr. Doherty is an esteemed clinician, a consultant in anaesthesia, and has been for the last 20-odd years. But also she brings with her tremendous both personal insight as a parent also, and as an academic researcher and publisher. Mary has published widely in many journals. She has individually authored and co-authored both papers, journal papers, and also chapters and books in many esteemed journals that you will be familiar with, like The Lancet and British Journal of Psychiatry and British Journal of General Paediatrics, along with other international ones. So as if that wasn't already busy being a parent and a busy clinician and a researcher, Mary has started a master's in research with University College of London South Bank, and is also a recipient of an award from the John and Lorna Wing Foundation for her research into, I think it is GP attitudes to autism, and also helping primary care service for adults with autism. So I look forward very much to your talk, Mary, and Archita, if you wouldn't mind putting up the slides for Mary's talk. Thank you very much.
Thanks, Fiona. I think hang on. I need to share my slides, but I can't while there's another one up. So I think Ajisha, you need, here we go. Yeah, okay, give me a minute. Okay, just give us a second and we'll get there. That should be my slides up. Is that correct?
So far, so good.
Okay, super, great. Okay, fabulous. Thanks, Fiona. Thanks for the introduction. I'm absolutely delighted to be here and to be talking about a topic that's been something of a taboo subject, really, in medicine until quite recently. And neurodiversity, it's an issue that affects us all. It's relevant to all of us in healthcare because we all encounter neurodivergent patients. Many of us have neurodivergent kids, and some of us are neurodivergent ourselves. And while we're used to thinking of diversity in terms of race and ethnicity and of course, gender and sexuality, we really need to start adding neurodiversity to that conversation. And I'm going to talk a little bit about my story, about my work with autistic doctors and medical students, some of the strengths and challenges of being autistic in medicine. I'm going to briefly touch on some of my research into barriers to healthcare for autistic people, both physical and mental health. And now I have to say I could talk about any of them for hours. So I'll try to be brief. I'll give a quick overview of each, and then we can come back to individual areas in discussion. But really, because of my intersectional position, as I said, as an autistic woman diagnosed 8 years ago, I'm a parent of 2 neurodivergent kids. As a doctor, researcher, author, and advocate, that gives me a fairly unique insight into some of the healthcare access barriers faced by our community. Up to now, most of my advocacy work has been UK based, but I've been working with the Royal College of Psychiatrists, the NHS Practitioner Health, the British Medical Association, GMC, advising on autism, and also as part of several international research projects. And this all gives me an overview, which brings me to a point where I want to really start thinking about the most important next steps as we consider how we want to support autistic people, and in particular, how we want to raise the next generation of autistic kids. So I'm going to start with my take-home messages. There's 3 of them, each with 3 parts. And the first and most important is that negative framing of autism perpetuates the stigma that's so pervasive, both in society and in healthcare. And this negatively impacts the mental health of autistic people. Secondly, autism is incredibly heterogeneous, but autistic professionals exist in all fields. Autistic doctors and med students are a hidden minority in medicine, but most don't disclose due to stigma. And thirdly, supports for autistic people cost little. Understanding is the primary need, and reframing our view of autism will save lives. So some of you may know me from Twitter, where I tweet as the Autistic Doctor. And as I said 8 years ago, after I'd given up work to care for my child around the time of his diagnosis, I was also diagnosed as autistic. And I'll be honest, I was terrified for my career at the time. Can you be autistic and work as a doctor? I had no idea. I didn't know any others. Now I know, yes, of course you can. And I also know that there are loads of us. So I work in Our Ladies in Navan, doing mostly anesthesia for general and orthopedic surgery, a little bit of intensive care medicine as well. So we've been busy during COVID. But here's my other job. I'm also a qualified ski instructor, and that's me teaching in Andorra a couple of years back. And in normal times, I spend my winter weekends up at the Dry Slope and the Ski Club of Ireland in Kiltiernan. And I tell you, I'm missing the snow this year. Well, that's the Munchkin. And he's now 13 and a confidently autistic kid. He's the happiest kid. He's currently in Germany on a ski training camp before competing at some international races at the weekend. But the thing is, and of course, while I've always been autistic, I had no idea about that until he was diagnosed. But then suddenly everything made sense. Now, it has to be said, his diagnosis at 6 was late, given his presentation. But sure, that was in part because I didn't see anything particularly odd about what were really obvious autistic traits. And then, of course, my own diagnosis a few months later, it just finally explained a lifetime of personal and professional difficulties. And to be honest, I'm still baffled. How on earth did I get to be a consultant anaesthetist in my mid-40s before anyone noticed, including, it must be said, several psychiatrists who I'd seen over the years. But sure, of course, there was little known about autism back then, and certainly little about, for women. But in fairness, now, it wasn't as if it wasn't obvious, if anyone had known what to look for. But at least thankfully awareness is growing. Now we do have community initiatives to raise awareness and understanding. In particular, the As I Am Autism Friendly Town project in Clonakilty, which was how I got into autism advocacy in the first place. DCU, Autism Friendly University projects, also specific awareness raising initiatives within medicine, such as the Autism Friendly Hospital projects, which were happening in several Irish hospitals prior to COVID, and hopefully we'll get back to that. In the UK, I just want to mention a fabulous NHS Different Not Less campaign, which was started in Kent and Medway by a vascular surgeon who's parent to autistic twins, which will hopefully be rolled out beyond the local region in the UK. I'd love to see it rolled out nationwide, and indeed to have something, similar here. It's so badly needed. But the thing is, medicine selects for autistic traits. There's loads of us in medicine. Loads of us actually meet the criteria for diagnosis. And in fairness, all is good until demands exceed capacity to cope. And then the wheels fall off. My belief is that autism should be specifically considered whenever doctors present in difficulty, or indeed medical students. Now, it has to be said that tweet's a bit old. I don't use ASPE or ASD anymore. I prefer condition to disorder, and mostly I just use autism. Also, it's worth noting that science and academia also select for autism, but yet due to the current stigma around the condition, most of us remain in hiding. I really hope that we can help change that culture. So it's possible to come out as an autistic or otherwise neurodivergent scientist, doctor, academic, and have our contributions valued without fear of negative career impacts. Autistic Doctors International, that's the peer support and advocacy organization I founded 2 years ago. And we have a linked group for autistic medical students. And that poster was presented at a recent anesthesia meeting. Now, obviously, I'm not the first autistic doctor, but I'm just one of the first to talk about it. And 3 years ago, I didn't know any others at all. I searched, couldn't find anyone else, which is, in fairness, why I founded the group. But in the 2 years that we've been in existence, we've been growing very rapidly. And we're now almost 500 between the two autistic doctors and the autistic med students group. But interesting, look at the breakdown of specialties. This was from a spot poll that we took a while ago. GPs are the most common, psychiatrists are second. And when we consider the relative number of GPs and psychiatrists, it's clear that autistic doctors are potentially overrepresented in psychiatry. And this was this is one of my first articles on neurodiversity, which was published in the Anesthesia News last December. And indeed, anyone who's worked in anesthesia might appreciate the logo that's down there just on the bottom, which shows two pieces of kit that we use for different anesthesia procedures, either an epidural or a general anesthesia, totally different, each suited to particular situations, but equal in their effect. Different, but yet equal. It's also worth saying that while the conditions generally associated with neurodiversity include ADHD, dyslexia, and dyspraxia, my work focuses on autism, so I talk mainly about autistic people. And it's also important to remember that neurodiversity is a concept. It's an idea which sparked a social justice movement. It's not a diagnosis. It's not a synonym for autism or indeed any other condition, and it's certainly not a euphemism for disability. And unfortunately, that misuse is creeping into popular discourse. So I'd love us to just be aware of that and resist it where possible. I'm going to skip over this one, except just to recommend the book edited by Stephen Kapp, Autistic Community and the Neurodiversity Movement, Stories from the Frontline. It's a fabulous read. And also just to mention the terminology, really, because while it's confusing, language really matters. Now, this was from the March edition of the Australian Journal of General Practice, which was focused on neurodiversity. Now, it's available open access, it's highly recommended, and has contributions from ADI members. I'll come back to a letter in response to this by myself and colleagues in a little while. But just to say about language, generally autistic people prefer to be called autistic rather than the person first language that's preferred for other conditions. And it's important to understand why. Person with autism or doctor with autism feeds into the stereotype that autism is some sort of a tragedy, separate from ourselves. But when you flip that around and view it from a neurodiversity perspective and recognize all the benefits that autistic people bring to the world, then it's easier to see the reality that autism it's a core feature of our identity. And that's important because of the prevalence of mental health problems in the autistic community, increased suicide rates, potentially up to 9 times the general population rate, and up to 80% of us experiencing significant anxiety and depression. And we know that developing a positive self-identity is protective. So it's really important to fight the stigma that surrounds autism, and that starts with language. I'm not going to go through what autism is, except just to mention for current thinking around adult autism, I would recommend the Royal College of Psychiatrists report, CR228, which I'm pleased to have contributed to. And just in terms of the recommendations, I love the first one. And it's relevant not just to psychiatrists, but applicable to all professionals working with autistic people. And it says, all psychiatrists should continue to improve their expertise in autism through training and experience, and particularly through familiarity with the autistic world. The second is that all psychiatrists should be able to recognize and treat psychiatric disorder in autistic people, distinguishing it from the features of autism, and be able to make the appropriate adjustments to their treatment and care and follow-up. And that just reiterate, we shouldn't need to spell this out, but we still do. Autism is not a mental illness. Lots of familiar faces there. Many need no introduction, all shining a spotlight on autism in the mainstream media. But let's look at some countless examples that we have in history. Unstoppable Brilliance is an interesting book by Professor Michael Fitzgerald, which looks at some Irish historical figures who may have been autistic. Now, it's important to say we can't make a diagnosis of autism or what was formerly Asperger's posthumously, of course not, but autistic traits are pretty easy to recognize in biographical or autobiographical writing, once you know what to look for. In science, we've Albert Einstein, Charles Darwin, Alan Turing, Marie Curie. But my favorite psychiatrist Dr. Robert Spitzer. Now, I first heard of him when I read Neurotribes by Steve Silberman. He was primarily responsible for the removal of homosexuality from the DSM-2 in 1973, which was the result of his single-minded and almost single-handed crusade to eliminate the psychiatric stigmatization of difference. His other major accomplishment was to save psychiatry from a crisis of credibility by systematically developing the DSM-3 and its subsequent revision. Now, this is the man who has been credited with saving psychiatry itself from extinction. He doesn't understand people's emotions. He knows he doesn't, but that's actually helpful in labeling symptoms. It provides less noise. And that was a quote from well-known psychiatrist and chair of the DSM-4 task force, Alan Francis, who also called Spitzer an idiot savant of diagnosis. To quote Steve Silberman, while Spitzer's eccentricities may have fallen short of meeting the criteria for Asperger's, the DSM-3 was the product of a mind that exhibited many classic qualities of autistic intelligence. I just think it's the most supreme irony. Wouldn't it be the most supreme irony if the man who created the Bible on which modern psychiatry was based was one who thought like us? And what more evidence could we need that diversity of thought within medicine is vital, and that we need to recognize and celebrate neurodiversity? But the concept of a condition once considered pathological before being recognized as a form of diversity, that has echoes in the gay rights movement. And sometimes when I talk about being an autistic doctor, I think of Dr. Dr. H. Anonymous, who was later identified as John E. Fryer, addressing the 1972 American Psychiatric Association Convention. He stood up on behalf of what they termed the gay PA. Now, he was wearing a mask and using a voice distorting microphone when he said, "I am a homosexual and I am a psychiatrist." This is back when homosexuality was not only considered a disorder, it was criminal. And look at the difference in societal attitudes over a generation or two. And it's my belief we need a similar paradigm shift in terms of how we look at autism. We know little about the prevalence of autism, particularly amongst doctors. It's a lot more common than we might think. General population rate, as we know, is 1 to 2%. But then there's the talk in the autism field of this lost generation of autistic adults who weren't picked up earlier, because it wasn't often recognized, and particularly for women. So I think, personally, I think the prevalence rates in medicine are higher than the population rates. We know there's an association between autistic kids and parents in healthcare. There's evidence of autistic kids being up to 6 times more likely to have parents in healthcare. And looking at GPs, one study showed 1% of GP respondents to a knowledge of autism survey disclosed that they were themselves autistic. We know of lots of doctors who have disclosed to the GMC for various reasons, even though it's not necessary to disclose. And as I said, we're almost up to almost 500 at this point. Between our two groups. Interestingly, our male to female ratio is 1 to 3. I've already mentioned the specialties. So I'll just move on to say the challenges that we face are common to autistic people, and particularly issues such as anxiety, transitions, sensory issues, information processing, executive functioning, communication challenges, difficulty accessing support and not being aware of reasonable accommodations, and also lack of knowledge of autism by supervisors is a recurrent problem, and that's going to be the focus of my MRes this coming academic year. But looking back over my career, I mean, prior to the diagnosis, my career was honestly undergraduate years, postgraduate years, lurching from crisis to crisis. And in hindsight, mostly due to unrecognized autism. And I was always fine with patients, but it was with peers that I would have struggled. And the main issue for me on a daily basis would be social and sensory. It's not pretty good at interpersonal skills mostly, but it's cognitive, it's not intuitive, and it's absolutely exhausting. But some of the issues that we face are qualitatively similar to those who might be more visibly autistic, particularly around sensory challenges. So I'd be very sensitive to lights and to noise, for example. And this picture is how an office would usually look. But that's how it can look on a high stress or a bad lights day. And days like that are really tough. Also, organizational challenges mean that there's no way I could cope with, particularly with the academic work that I'm doing alongside the clinical work, without the support of a fabulous autism aware occupational therapist. Absolutely no way I could manage. But it's important to recognize the consequences of undiagnosed autism, because while lots of autistic doctors are managing fine, particularly those of us who've made it through the training years and found a nice square hole to fit ourselves into, the recurrent narrative among some autistic doctors tends to be personal distress, professional difficulties, and often a truncated career. Early retirement is common, and indeed after such a long break, I think that was probably expected of me too, amongst some of my clinical colleagues. But the consequences of a misdiagnosis are not just career related. As we mentioned, and there's some trigger warnings for the data that's coming up. You know, if you're not familiar with the figures, it can be upsetting. But up to 80% of autistic adults having at least one co-occurring mental health condition, and our mortality is 2.5 times the general population rate. Suicide is an autistic crisis, and it's a huge issue for us in medicine, particularly in anesthesia. From the literature, we know that 2/3 of autistic adults have considered suicide, 1/3 have attempted, 15% of those hospitalized after an attempted suicide have a diagnosis of autism. Preliminary data from a psychological autopsy study shows 11% of those who died by suicide had evidence of being autistic. And I know, although we don't have the data, I know that there's a crossover between physician suicide and autism. And therefore, we need to specifically consider the possibility of autism in every doctor or medical student in difficulty, because it masquerades as anxiety, depression, bipolar disorder, OCD, eating disorder, substance abuse, and particularly the borderline personality disorder. And remember that neurodevelopmental conditions often don't come alone. So ADHD, dyspraxia, common co-occurring conditions. So whenever any of these conditions are present, we need to add autism, I think, to the differential diagnosis. But more than anything, it's vital that we accelerate that move towards a strengths-based approach and resist that tragedy narrative that's just so pervasive across healthcare. Looking at my own work in this area, this was a survey looking at the experiences of autistic adults accessing mental health services. I'll skip over a lot of that, but just to say that the suicide data in particular is absolutely appalling. This was 101 autistic adults in a community setting. How have we reached a situation where, as a community, we're so marginalized and so misunderstood that 86% of that population have felt that life's not worth living? 47% had attempted suicide at some point. 65% had engaged in self-harm, which is not something that's widely associated with autism amongst healthcare providers. And for 21%, this required medical attention. And I know that few of my colleagues treating patients following an episode of self-harm would think of autism. Over a quarter had been psychiatric inpatients, 11% detained under mental health legislation, 10% experiencing restraint, 28% use alcohol to manage mental health issues, with 11% using illicit drugs. And this was the poster about this project, which we presented recently at the Autism Research Conference INSAR, which gives a little bit more detail, including where autistic adults turn to for help when in mental health crisis. And looking more closely at this, the positive axis here shows where autistic adults seek support for mental health challenges, and the negative axis where they do not. And it's striking the number who would not seek help when required from psychiatrists, from mental health services, or from emergency departments. And the ongoing qualitative analysis will hopefully shine some light on the reasons behind this. But this was the physical health project. And this is where all of my advocacy work really started, was as part of the As I Am Clonakilty Autism Friendly Town project, which was back in 2018. And initially, I was asked by As I Am to develop some autism training for healthcare providers. And I wanted to ensure that that training was informed by the lived experiences and the concerns of the autistic community. So I undertook a discussion workshop and survey at Autistic, which is a residential conference by and for autistic adults, which happens annually in the UK. And then that was followed by an online survey comparing autistic adults, parents of autistic children, and a control group. We asked, what do our GPs need to know? What works well? What would make visits easier? And what are the self-reported consequences of delayed care? Now, our paper is currently in review, and while I don't have time to go through the results in detail, I do have a preprint available, or if anybody wants to contact me for that. The majority of our 860 respondents were autistic. 74% had a formal diagnosis. And it's interesting to note that the single greatest barrier to healthcare was difficulty using the telephone to book an appointment. The consequences of access barriers to healthcare included untreated physical conditions, untreated mental health conditions, late presentations, emergency admissions, and more extensive treatment or surgery being required. And most worryingly, almost a third of autistic respondents reported a potentially life-threatening condition which went untreated due to inability to access healthcare. Many autistic adults have no access to primary care whatsoever. And it was interesting that there were no differences with or without a formal diagnosis in terms of difficulty attending, the barriers faced, or the adverse health consequences suffered. So based on this, I believe these are some of the most important factors contributing to the excess morbidity and mortality in the adult autistic community. And so they're really important to address, and particularly in the Irish context, because potentially large numbers of Irish autistic adults, many of whom will be undiagnosed, will be facing significant challenges accessing basic healthcare and are likely to experience increased morbidity and mortality. And yet, outside of the intellectual disability services, we're an invisible cohort in Irish healthcare. So we need to urgently develop diagnostic and support services for autistic adults as part of our public health system, because it's deeply concerning that a condition with such profound health impacts currently receives no funding or provision in primary care, secondary care, or social services. Both of my surveys show a worryingly high rate of autistic people not registered with any GP. And as I mentioned, the greatest barrier is the phone. So I'm particularly concerned about our community during COVID with the move to telehealth, because this is a matter of human rights. Equality legislation requires that that accommodations be made for autistic people, for disabled people, so that, for example, failing to provide an alternative to the use of the phone to access your services is potentially a breach of your duty under that act. But it's not just a legal requirement, it's a moral duty. We'd never deny a wheelchair user access to healthcare services for want of a lift or a ramp, but accessible communication alternatives to the phone are equally important. Education and training is required for all staff in both physical and mental health care, and this must be informed by the lived experiences of autistic adults. It's ideally developed and delivered by autistic healthcare providers. So we need to challenge the assumption that we often have as professionals that autistic people are our patients, our clients. We need to recognize that autistic people number among our colleagues. And making healthcare services autism friendly involves first recognizing, valuing and learning from our autistic colleagues. So some of the work that we've been doing in ADI around raising awareness in this issue, this was the editorial that we recently published in the British Journal of General Practice on supporting autistic doctors in primary care. And I'm sorry, the quote's very, very faint there, so it's not easy to see, but it says, we find that discussing the existence of autistic doctors elicits one of two contrasting reactions among medical colleagues: disbelief, or a recognition that, well, of course, many of our colleagues are autistic, but it's not something that is openly talked about. This one was a poster that we presented recently at the Royal College of Psychiatrists International Congress in June this year, looking at autistic psychiatrists. And this was produced by the autistic psychiatrists subgroup of ADI. Two other issues we've done recently. The first I referred to earlier, it was a letter in the Australian Journal of General Practice, and it was in response to the March edition, which was focused on neurodiversity. And really that was written with colleagues from the Royal College of Psychiatrists and the Royal College of General Practitioners. And the point that we were making was that GPs are commonly the first professionals consulted regarding child development or indeed adult diagnosis. So there's a unique opportunity at that point to influence either family dynamics or indeed individual self-perception, which has consequent effects on mental health in later life. And it's important to raise this point because all too frequently an autism diagnosis is framed negatively with language and demeanor more typical of a Breaking Bad news type consultation. So we really need practitioners to resist this tragedy narrative and accelerate that move towards a strengths-based approach. And not to deny at all the serious disability that can be associated with autism or the heterogeneity in presentation. But importantly, the way in which autism is framed will have a profound effect on outcome. So that was that letter. The other one was a letter in the Lancet recently. It was the neurodiversity concept viewed through an autistic lens. And that was written by the ADI research group in response to an article that was very much introducing the concept of neurodiversity to a psychiatric audience, but it was done very much from an outsider perspective. So we wrote and described our insider perspective. Again, that's open access. But it's really important, I think, to challenge the myths and misconceptions and to realize that autism, it's not just the stereotypes. Being autistic, it's a different way of being in this world. It's a different way of experiencing the world, of communicating and of relating to other people. And the key point is that if you are not autistic, you're going to struggle to understand that. And that's the concept termed the double empathy problem, which was described initially by autistic academic Damien Milton, who gave a talk earlier in this series. And it's worth looking up if you're not familiar with it. But it's really important to understand that, because it does not mean, being autistic, it does not mean that we lack empathy. It does not mean that we're unlikable or worthless. It does not mean that we're deficient, but it does mean that we're different. And the myth that autistic people lack empathy is probably the most damaging myth at all. The assumption that we don't feel empathy, sometimes even that we don't feel anything at all. Look at just that bottom left corner, just, nothing, like a rock. It's what society thinks I can feel. And the reality is, not only do we feel empathy, but many of us are hyper empathic, often to the point where emotion is overwhelming. And we may show empathy differently to non-autistic people, but that doesn't mean we don't feel it. And given that the capacity for empathy is associated with our very humanity, this myth has led to the dehumanizing of autistic people throughout history. So understanding this point is really, really vital. So important that we reframe our view of autism so that we can genuinely appreciate the humanity of our autistic colleagues, our family members, and even our own autistic selves. And then I just want to move on to the concept of preventing mental illness in autistic people, because let's consider the goal from the outset. What is our goal? In my view, the optimal outcome is a content and healthy autistic adult, regardless of what that looks like. And to do that, we need a multi-pronged approach. We need a neurodiversity affirmative approach to assessment and diagnosis. We need initiatives to challenge stigma, such as the SARN network, which is the Stigma in Autism Research Network. We're addressing it in healthcare. In education, we have projects such as the Autistic School Staff Project. And I believe that together, initiatives like this will enable prevention of mental illness. Because we need to challenge the almost automatic assumption that autism means poor mental health. Yeah, it does for most of us currently, but let's think about how we want to raise the next generation of autistic people. It doesn't have to be like that. 3 other projects which will contribute to the prevention of mental illness in autistic kids, all from the UK. Leans, learning about neurodiversity at school, fabulous project. Developed by Sue Fletcher Watson and colleagues. And the idea is to teach the concept of neurodiversity at a really early age, so that understanding and acceptance is just built into a child's life as they grow through school, hopefully with the outcome that by the time they get to the teenage years, they haven't had their self-esteem destroyed, and then need to go and see Dr. Emily Lovegrove, who is an amazing autistic psychologist who's written on, her work is mostly on bullying, and she's written a fabulous book, Autism, Bullying and Me, and it looks very much at the development of good self-esteem and confidence. But I'd like us to start considering those issues before kids get to the point where they're being bullied. It's worth saying that the Leans project will have some free resources available in spring, which will be able to be used in schools. I'm really, really excited about that project. The other one to mention is the National Autistic Task Force. NAT is made up of autistic parents of autistic kids and adults, many of whom have very high support needs. And it outlines what good care for autistic people looks like in practice. And it raises the issue of the need for autistic input into care settings, autistic input into training and education, and how it's vital that we promote the use of alternative and augmentative communication strategies for autistic people. And so that's available online and well worth a read for anybody, particularly in the provision of care or residential services for autistic people. Finally, just to mention what's happening in Ireland, this series of webinars, I think, is probably the most exciting initiative I've seen for a while. It's organised by the Psychological Society of Ireland Autism Special Interest Group, with special thanks to Davida Hartman from the Adult Autism and the Children's Clinic. And Davida has recently been appointed adjunct professor at UCD. So I'm looking forward to a lot of evidence-based research around this, just because Davida's been pioneering the neurodiversity affirmative approach here in Ireland. And we've seen the benefit of that in ADI, where several of our members have been assessed using that neurodiversity affirmative approach. And then others have gone through the more traditional deficit-based approach. And the difference is phenomenal. I mean, those who've had a neurodiversity affirmative approach are streets ahead in terms of that journey towards good self-esteem. So this series of webinars is looking at adapting that approach to children, which I think is just so important. Finally, I'll just mention that being autistic it's like a parallel universe at times. And for most of us, just feeling so different, even as kids, such a common experience. So that's worth bearing in mind for anyone wondering if this fits for you. Did you feel different to your peers, even as a child? And it's important to just not assume that you understand autism unless you really do. Because while it's very easy to recognize once you know about it, our medical training doesn't prepare us. Often our concept is based on stereotypes or what limited exposure we've had. And while it is challenging to find specialist advice, but it's really important to be able to do that. And so I'll just finish by saying, in summary, consider autism as a differential diagnosis where relevant, resist that tragedy narrative, and remember that we're good doctors. And then there's some links, which I'm happy to share.
Mary, thank you very much for that excellent presentation and for allowing plenty of time for us to discuss. Before I ask you any specific questions, there's been a huge amount of interest in your slides and the wealth of information you've put on there and the resources that you've included. May we make those available to the audience? Would you be able to send them to UCD Chaz and we can put them on the site? We have recorded the event so people can go back and listen to it themselves, but it would be fantastic to have the slides and reassure everybody.
Sure, happy to do that.
So the first thing I wanted to tease out a little bit with you as well, and again, I saw some chats coming while you were speaking. It was talking a little bit about the Autistic conference data that you presented in 2018. And you had a total of 860, and I know this is getting into a little bit of the detail, and it's not that I'm a kind of a data nerd myself, although I must say sometimes I do like it. But because your findings are potentially so significant, it really is very important, I think, to put a little bit more context around it. Some of the people who responded, you said, were individuals, you called them autistic adults, some of them were parents of autistic children, and then some of them were a control group. So could you just tease out a little bit more in terms of, I think you said that one of the issues was that it was looking at their interaction with GP services, and I'm not sure what else your study covered, and I might have missed some of that data, but what I did take from it was the significant number of people who had difficulty in using the phone and it didn't matter whether they were diagnosed formally or not.
Mm.
So could you just back up a little bit and maybe create a little bit more detail about that study?
Sure, yeah. Yeah, I mean, there's so much to say about it. It's currently in peer review, so I'm really hoping that it will be available soon. So I started with a survey at Autistic. Now, Autistic is a conference that happens in the UK. It's run by and for autistic people, and it's fabulous because all our autistic needs are just met. It's just such a perfect autism-friendly environment. It's brilliant for the kids. Probably my son misses it so much. It's probably the only place that it's, kids get to see autistic adults. Anyway, I'm gone off on a tangent. I could talk about Autistic all day. I just love it. I miss it so much. Anyway, back to the study. So I started specifically asking, what do you wish your GP knew about autism? So there was about maybe 180 adults at Autistic that year, I think. And I got responses from 72 autistic adults. So what I did was a sort of an analysis, it was a thematic analysis really without knowing what the concept was at the time. And then I used that data to develop an online survey, because what really came across so strongly through the Autiscape data was the telephone over and over and over again. And I didn't realize that this was such a big issue. So I started to wonder, okay, and I hadn't asked specifically about the phone. So I started to wonder, if we asked people specifically, how many people would say they had a difficulty with the phone? And actually it was 62% of the autistic group. And I think the comparable group in the control group was 16%. So a really significant difference. When we asked about use of the telephone in general, 78% of the autistic group said they avoid using the phone. And I do too. I absolutely hate it. I will, never use the phone unless I absolutely have to. I do in a work context, but only when I have to. And even then I'll avoid it if I can. And the thing was, when we looked at the correlation between people who had difficulty and adverse consequences, we found that people were those who had difficulty using the phone were much more likely to have self-reported adverse health outcomes. There was no difference between, we compared the autistic adults who had a formal diagnosis and those who didn't, and there was no difference. The autistic adults who were self-identified had exactly the same level of difficulty accessing barriers, the type of barriers that they faced, and most importantly, the self-reported adverse health outcomes. And that's things like people not going for screening, not turning up with sinister symptoms, turning up with late stage cancer rather than early treatable cancers. Some of the medical data in some of the free text was just shocking. People having chest pain, somebody who'd had, a heart attack previously at home with new onset chest pain, knowing it was another heart attack, and could not make himself pick up the phone, call an ambulance, get himself to ED.
Mary, coming back to the specifics of difficulty with the phone, we know about obviously communication being verbal and non-verbal, and the importance of body language, tone of voice, expressions and all the rest of it. I don't know if you ask the individuals, or if you have subsequently, or from your own experience of not liking the phone, is it because that non-verbal component is missing in the phone?
Yeah, definitely. Yeah. One of my co-authors, Stuart Nielsen, describes using the phone as the distilled essence of verbal communication. And there's nothing else. There's no context. It's even to do with cues around timing, tone, facial expression. Yeah, no, absolutely. It's with all of those things gone. It's just so anxiety provoking. An unexpected phone call is enough to wipe me out for a day. That's it. Nothing else happens if I get an unexpected phone call. And that is such a common experience.
Because making that, we're talking about medical consultations, but it doesn't matter whether it's job opportunities or ordering your shopping online, or getting a play date for your kid. Is there a way you think that we should be thinking about augmenting phone conversation, or always doing FaceTimes as opposed to regular telephones? Because most people now have got quite used to doing more WhatsApp, FaceTimes and Zooming, you know, because we've been doing it so much because of COVID.
Oh yeah, definitely. But email, you know, I mean, when we asked people what they wanted in terms of what would make visits easier, one of the big things was to be able to email in advance what the consultation was about.
So a bit like setting your agenda, your points, and you know, that works if you've ADHD, reminding you not to forget things.
Absolutely.
Okay. So I think that's very interesting, and I think it does make us think about, I mean, it goes back to what's good that has come with COVID, you know, remote psychiatry is something that never would have been thought about before, but now because we've had to do it on account of restrictions, the value of it has become evident. And, you know, they talk about, you know, some of the silver lining with COVID. I think obviously it has to also go to, you know, actual telephone consultations and a little bit. Are you working with GPs around that? Are you trialing that at all?
We have some research underway, as you mentioned at the beginning, with LSBU, where we're looking at various interventions that are kind of aimed at improving healthcare access for autistic people and improving the outcomes, such as the mandatory training, the Oliver McGowan mandatory training that's being developed and rolled out in the UK. We're looking at things like health checks, annual health checks, hospital passports, that sort of thing. We do have an article actually in preparation for around telehealth and telemedicine, which is due for submission. I must remember that this week. But it's a really big deal. I mean, the problem is that the disability services, particularly the kids' disability services, CAMS, they all rely on telephone contact. There's no alternative. I remember having a battle to, you know, actually be able to email just simply for an appointment or to change an appointment, you know, and having to really strongly make the case. And this is both with the GP and with the disability services. You know, this is an accommodation for autism. I am autistic. This is a long-term disability. And this is not something I'm choosing not to do. This is something I literally cannot do. I mean, when I say I can't do it, it's a bit like, you know, can you walk up, you know, 20 flights of stairs with a rucksack on your back? Probably, but you won't be okay for a week afterwards. Do you know, it takes so much out of us to do it. That really, it's just not comparable to anybody else who's not autistic.
I guess all of this goes back to, you know, with what a lot of speech and language therapists and occupational therapists would do routinely in their practice is augmenting social skills. And you don't have to be autistic, you don't have to have ADHD, you can be anywhere along that spectrum. And the benefit of helping people with communication, it probably would also apply to emailing, because there is a tendency in writing to be very curt for some people. And that comes across as a bit offensive, or I can't really read what you mean without all the nuance or without your tone or your voice as well. So maybe we also need to be thinking about, is there a role for encouraging people to be less judgmental when they read an email or a letter, not assuming that curtness is anger or irritation or demandingness?
So much, absolutely. That goes right across the board in terms of communication. And it's one, I think, of the benefits of just being openly autistic at work. You know, if I accidentally blank somebody, at least they understand that I'm not being rude. I'm just, you know, way off and thinking of something else. Or, you know, the mask slipped and I just forgot to pay attention to the social niceties. I think that's very relevant. I think it's very important to teach autistic people, particularly autistic students, how to write emails, because they can end up very long with an awful lot of detail. And actually, I won't go off on that tangent. But in terms of social skills, I have to be honest, I'm not a fan. Teaching autistic kids social skills, for me, that's a big red flag. I don't believe it works. I think it teaches masking. And we know that masking is associated with really poor mental health outcomes. We know it's associated with increased suicidality, and it doesn't work. No matter how much you teach autistic kids social skills, they still look autistic. They still look odd.
Because certainly when individuals will come to a clinic and because I work with children generally, sometimes the child is also identified as having a problem, but oftentimes the parent is in agreement. And together they're looking for support around social engagement. And as I say, this doesn't just apply to individuals with any diagnosis, it just is contributing to distress that they're having. And so helping them repair something like your eyesight is bad and putting on glasses to help them, gives them some skill set that allows them to engage. Do you think there's a risk if we assume that all social skills support is masking, which I don't believe it is? I do hear what you're saying about, you know, we should be able to say, this is my areas of difficulties, of deficits, of weaknesses, and I may or may not want to do something about them. But I think that if we're not careful, there's a worry that parents who are coming for a service here, everybody's saying, don't mask, you know, don't try and help somebody with eye contact because it means you're saying that you shouldn't have poor eye contact. Is there a balance there?
There, sort of. I would tend to think of teaching social awareness, almost like a second language. You know, the risk is when you're trying, and it's something that parents commonly feel is the assumption that, well, if my child looks like a neurotypical child, then they'll fit in better and then they'll be happier. And actually, I don't think that's the case. I think it's really important to value autistic ways of communicating. And I think that's what needs to be taught to peers, schoolmates, to parents, to families, to educators. I think that is so important. And then as kids get older, it's important for them to learn to understand how neurotypical or non-autistic people communicate. That is genuinely very valuable, but it's learning it in the same way as we might learn a different language. And for me, I mean, an analogy I'll often use is, you know, I speak neurotypical pretty well, but I'll always have an accent because it's not my natural language. And the thing is, even in medicine, we make allowances for our international colleagues when they don't speak English perfectly, or they make presentations with, you know, grammatical mistakes, spelling mistakes, and we just discount it because, well, you know, they're not native speakers, when we'd be horrified if a native speaker did the same. And I think we need to move towards you know, an attitude similar to that for autistic people and in terms of autistic communication. Because otherwise we're just risking mental health crises. And that's why places such as Autscape are so important. It's where autistic kids and adults can just be in autistic space and just recognize the value. Because the thing is, there is peer-reviewed evidence which shows that autistic people communicate amongst ourselves just as effectively as non-autistic people do. And that's work, again, it's similar, it's work done by Sue Fletcher-Watson, who's running the LEANS project at the moment, along with Catherine Crompton. And, you know, they have shown that autistic people in a communication chain transfer information just as well as non-autistic people do, even better in some parts of the chain. And you know, it's like other work that's really interesting looks at communication between autistic and non-autistic dyads, and the rapport developed between autistic people is similar to that developed between neurotypical pairs, but it's when you mix them that's when the communication drops off. That's when the rapport drops off. And the thing is, this is evident even to observers, to neutral observers who don't know the diagnosis. You can see it on a video. And no amount of social skills training, no amount of masking will overcome that. So I really believe that acceptance, understanding is the only way forward. If we want to get kids to a stage where, you know, they're happy and healthy as kids, they're happy and healthy and content as adolescents, so that, you know, they grow up with a good sense of self. Like, and the thing is, as I've said, I've two neurodivergent kids, one of whom, there's quite an age gap, one of whom grew up in, when all we knew was that pathology paradigm. You know, what's wrong? How do we fix it? And the other one grew up in that neurodiversity paradigm. And I see it. I see the difference in mental health, the difference in self-esteem. And the thing is, for adults coming to a late diagnosis, or adults just trying to battle through that destroyed self-esteem, it's a really, really hard road to come back from that. And the way to do it is to prevent it in the first place. Let kids grow up with a good sense of self-esteem. Let them grow up as confident autistic kids.
Yes. Mary, let me pass you over to Ken, because I see from the Q&A and indeed the chat that this is kind of tapping into some issues that some of the audience would like to pose to you or agree with or disagree with or query. Ken, would you like to present those to Mary?
Oh, just we'll try and run through them as quickly or as many as we can, as quickly as we can. So the very first one in is, obviously just you've told about your experience of being a doctor and what happened after you came out. So is there a benefit of being out or role modeling in your profession?
Oh gosh, yeah. Oh, absolutely. Yeah, it's twofold, because it's so beneficial to me because it means that I don't have to mask. Now, obviously, I will present a professional face to my patients, and that takes effort. But whereas previously I'd have been trying to do the same thing with colleagues, now I don't have to. Now I can be honest and open with colleagues if I'm having sensory challenges, communication challenges, executive functioning issues, and people understand. And it has just made such a difference, whereas before a day's work was absolutely exhausting. Now it's not. And now it's much easier to just, be professional with patients, obviously be professional with colleagues, but in an authentic autistic way. But the other thing is as a role model, because the thing is there are so many neurodivergent kids in school, adolescents, university students, med students, who just have this sense of shame, and the stigma around autism just prevents disclosure. And yeah, so to be able to do that, to be able to be a role model is super. And I mean, I hadn't intended to. The way I came out was through working with an autistic colleague, with a colleague who was clearly in difficulty, and her career was in jeopardy. And it was clear, it was obvious to me that she was autistic. And being able to recognize that and being able to explain that and intervene was able to just salvage that situation completely. So that's why I came out in a professional context. But the benefits have been far greater than I would have anticipated.
Just building on your international experience, there's a question in saying, my daughter's 25. She's a brilliant violinist writer, and she's not been diagnosed with, but believes that she probably has. We think she has as well. They live in the New York area, United States, but they say there's negative resources and attitudes. So could you recommend any international organizations that are like-minded with your wonderful research?
Gosh, when I think of the US, I think of ASAN, the Autistic Self-Advocacy Network. They would have the most knowledge about resources across the pond.
Okay, very quickly, just a question from Vicky. She talked about the services not being great. We really need more investment. Any thoughts on how we could improve services in Ireland and possibly internationally?
Oh, it's so difficult, isn't it? I think data really, is the most important thing, because as I said, we're an invisible cohort. People don't realize that there are so many of us, don't realize that we have so much difficulty in terms of healthcare particularly, and also in terms of social supports. It's really difficult for autistic adults who don't have an intellectual disability, for example, to get social support. It's practically impossible in this country at the moment, but we really need to capture that data.
May I jump in there, Mary, and just ask you, because obviously, ultimately, as a child, your biggest environment is the school environment, and autistic people have so many strengths if they're in the right fit between their environment, the style of learning, and the outcome. Take yourself as a very experienced clinician and researcher who's done very well. We've heard all about the Silicon Valleys, etc. So the big barrier to me seems to be having a child be in a situation where they can learn in the way that they learn best, to be able to both show everybody what they can do, but also do it for themselves and achieve and have a job that pays them money, because we know about unemployment as well. So if you could only focus in one area, do you think it should be in primary and secondary school?
Yeah, I do actually. I think if we did education well, there would be a lot less need for mental health services, for sure. Yeah. Now, having said that, the situation for mental health services, as you well know, in this country for autistic kids is just absolutely abysmal. Kids are falling between two stools. People, kids can't get seen in cams because they're autistic, can't get seen. It's just, we all know that. It's just awful. But a lot of it is to do with data and getting, recognition of the numbers, the issues. But definitely education is just so important. And that's why I'm so excited for the LEANS project, and when that data becomes available, because we need our educational professionals to have an understanding. It's the same recommendation as for the, from the psychiatrist report, become familiar with the autistic world.
Is there
the challenges.
Any plan for the LEANS project to come to Ireland?
Oh, I would love it to happen. I think even getting it from Scotland into England at this point is going to be difficult. But the resources will be available, and they're due out in March. So I'm really excited for that. I think a lot of the schools are taking it on. I mean, the work that As I Am is doing with schools is just absolutely fantastic. Middletown is doing some great work as well. And just what I'm really excited about is some projects that I know are happening within education where autistic teachers are involved in the steering groups. And I think the Autistic Schools project is something I'm not sure if I mentioned it. I meant to. If I didn't, I certainly meant to. The Autistic School Staff project is run by Dr. Rebecca Wood in the UK. And that is, it's similar to some of the research we're doing in ADI. And actually we were inspired by Becky's work. It's looking at autistic school staff, so teachers, head teachers, teaching assistants, ancillary and support staff in the UK, and they have some data available. There's a couple of reports that are available, freely available online. So I would suggest people with a particular interest would look up the Autistic School Staff project, because it's just so important. It's the same as in healthcare. Getting the perspectives of autistic teachers into education is absolutely vital, because it's like what I said, if you're not autistic, you just don't see the world the same way we do. So you won't see the triggers, you won't see the sensory challenges, whereas autistic people just do instinctively, because we understand each other. We also recognize each other as well, pretty easily, which is
Last question, if you can answer it in 1 or 2 minutes, because we're already over time. Ken, was there another question you wanted to pose?
Just very quickly, just more of a personal question than anything. When I was looking at, preparing for this, and I went, do I know any autistic doctors? And I went, I don't really. And the only thing I could come up with was Sean Murphy from The Good Doctor, which you had on your very last slide. And I'd say, so what's your impression of autism in the media, and particularly as portrayed on television? By the way, we have an autistic child ourselves at home, so I think Atypical is a wonderful program, but just wondering what your perspective is.
I love The Good Doctor. I mean, it's horrendously awful in terms of realism. And there's times you'd be just screaming at it, and it's so stereotypical. But at the same time, there's some stuff that's really, really good. Like the visual, I remember seeing some of the special effects around the way Sean visualizes things, and it just resonates with me. In the same way as, if you remember the photograph that I showed about the office with the lights, that's the kind of thing. When I looked at that, now I'm not saying that my visual perception is distorted to that degree, but I recognized it in the way you might recognize a caricature, for example. It just seemed, it's familiar. And the other thing that really struck with me, if you remember, there was one episode where he was looking for a screwdriver, and he just couldn't find a screwdriver, and nothing else would do, and he was having an absolute meltdown because that registered. I felt that, but just one thing you said, Ken, to say you don't know any autistic doctors. You do.
Okay.
They might know that they're autistic, or they mightn't be telling you that they know they're autistic, but you do.
Thank you.
Well, listen, Mary, in the interest of time and people going home to whatever it is one does on a Thursday at 6 o'clock, I want to thank you most profusely for your honesty, your candor, your enthusiasm, your advocacy, your academic excellence and know-how. So this is tremendous, the work that you're doing, and please continue. And obviously anybody in the audience that is interested in some of the things and can get them on your slides, it is about, like if there's a good program in the UK or Australia, it's getting that and trying to see, is there a backdoor into Ireland, because there's one thing about the Irish people, they're a can-do person. I mean, I know we're very much, you know, we don't give ourselves claps on the backs or whatever, but there is flexibility within our system that you don't get elsewhere. So it would be nice to see all of that happening. Thank you to everybody who has attended today, and to Ken and Archita for helping us with it. We're having another session. Do you want to put up the slide for when it is? And we would welcome you all back. Do you have that, Archita? Or I'll find it in my diary on the 28th of October. You don't have, maybe the next slide will give you the list, that's right. And I'm not sure if we have a time for that. We have Ginny Russell presenting. But in any event, guys, you know where to find it on the Eventbrite space, and that will give you the correct time. I haven't it in my diary as yet. Ginny, you're not finding the time on it, no? Or Archita?
No, we don't have.
Okay.
I don't have the time.
So watch this space, guys. Apologies about that. Thank you all very much for presenting, and have a wonderful weekend that's happening soon, and look forward to seeing you in October. Thanks again, Mary. All the very best.
Bye.